Hi, my name is Lauren Fontenot, and today I'll be doing my presentation on myocarditis. I will cover general features, clinical assessments, diagnosis, treatment, and prevention. I chose this topic after my pediatric cardiology rotation. One of the patients that we were consulted on in the hospital had myocarditis. I thought that experience was a great learning opportunity to further my knowledge about a topic that I was not previously confident in. Myocarditis can be tricky to recognize and diagnose due to the multitude of varying clinical presentations. I hope my presentation gives insight to a challenging but interesting topic. Myocarditis is inflammation of the cardiac myocytes, which causes cardiac injury. The incidence is believed to be underestimated due to the condition's varying presentation. However, incidence in children ranges from 0.26 to 2 cases per 100,000 children, with a male predominance and bimodal distribution. Roughly 32% are diagnosed under the age of 4 years old, and 41% ranging from 15 to 18 years old. Viral etiology is believed to be the most common cause, with a recent shift to specifically parvovirus B19 and human herpes virus 6. However, other etiologies such as infectious, autoimmune, medication-related, and hypersensitivity reactions remain in the differential. Symptoms vary based on the severity at presentation. The most common symptoms include viral prodrome, fatigue, fever, dyspnea, chest pain, and syncope. Severe cases may present with heart failure, arrhythmias, and sudden cardiac death. Physical exam reveals tachypnea and tachycardia. In severe cases, hepatomegaly, respiratory distress, murmurs, diminished pulses, edema, and cyanosis are present. CK-MB and troponins are typically elevated, and in cases of acute heart failure, BNP and NT-proBNP are also elevated. Nonspecific inflammatory markers such as leukocyte count, sedimentation rate, and C-reactive protein are elevated. PCR has a high sensitivity for detecting the most common viruses involved in myocarditis, while IGRA, or serodiagnosis, is run to exclude infectious etiology. First-line imaging includes ECG and echo. ECG is consistent with tachycardia, concave ST segment elevation, and low-voltage QRS complexes. Echo depicts systolic impairment, thickened myocardium, or left ventricular dilation. Cardiac MRI has become more commonly used to identify myocardial injury. This imaging modality has replaced CT and radionucleotide evaluations. Though endomyocardial biopsy is a gold standard, it has fallen out of favor due to its invasiveness and increased rate of false negatives. In this picture, picture B, is an example of a cardiac MRI which depicts a mid-wall and subepicardial distribution of increased signal intensity in the left ventricle. The mid-wall is represented by the solid arrow, and the subepicardium is represented by the dashed arrows. And this imaging is a T1-weighted early gadolinium enhancement. Acute myocarditis is more commonly associated with systolic ventricular dysfunction. Ventricular dilation may be present or absent. Fulminant myocarditis presents with hemodynamic instability, cardiac shock, and a thickened septum on echo. Chronic myocarditis will have positive inflammatory markers with normal ventricular function. Treatment begins with appropriate triage. Early intervention is needed to decide whether the patient should be admitted to a pediatric facility with expertise in mechanical circulatory support and transplantation. Patients who should be considered for transfer include those with acute or fulminant myocarditis with secondary cardiogenic shock, cardiorespiratory compromise, and significant arrhythmias. Antiarrhythmics can be considered, along with temporary transvenous pacing. Continuous cardiac monitoring should be used while inpatient. Low cardiac output can be treated with inotropes, milrinone being first line. Epinephrine and dopamine are reserved for cases with associated hypotension and cardiogenic shock. If ineffective, IV calcium chloride and vasopressin can be considered as adjunct therapy. Oral heart failure medications such as ACE inhibitors, beta blockers, aldosterone antagonists, and diuretics are started once the patient is stable and past the acute phase of the disease. These medications will be continued upon discharge to prevent further myocardial remodeling. The duration of continuing heart failure medications is controversial. Some studies have shown benefit with continuing the medication regimen for 3 years post-acute illness. Immunosuppressive therapy with NSAIDs is common practice, along with the combination of IVIG and high-dose steroids. NSAIDs and colchicine have proven effective as monotherapy in mild cases. These medications have been shown to improve left ventricular systolic function. Interferon alpha and beta are newer medications, and their efficacy is still being studied. If active viral infection is found, the patient can be treated with subsequent antivirals. Upon discharge, the patient should be followed frequently with resting echo, 24 Holter monitoring, and exercise ECG completed within 3 to 6 months following acute illness. Children should abstain from competitive sports until left ventricular systolic function is normalized and there is absence of arrhythmia on Holter monitoring. Preventative measures include yearly flu and COVID vaccinations. Staying up to date on the CDC immunization schedule is also highly recommended. Myocarditis has a high rate of survival, averaging between 75.6 to 98.6%. However, prognosis is largely dependent on the severity at presentation. Indicators of poor outcomes include tachyarrhythmias, reduced ejection fraction, and elevated BNP and troponins. Roughly 52% of patients had normalization of ventricular function 2 years following initial presentation. The development of myopathy years following initial incidence due to ventricular remodeling has been reported. Studies have also proven an increase in the incidence of sudden cardiac death due to arrhythmias. All right, thank you for sticking with me through the end of this presentation. If y'all have any questions, please feel free to email me and I'll drop my email in the comments. Thank you.